Hi, I'm Dr. Ryan Maves. I'm going to be speaking now about implementing crisis standards of care, and more broadly beyond that, methods by which we can help start the planning for allocation of scarce resources in times of public health emergencies, such as we're seeing right now with COVID-19. I have no relevant conflicts of interest, financial or otherwise, and the views expressed in this presentation are mine and do not necessarily reflect the official policy or position of the Department of the Navy, Defense, nor the U.S. government. So I think we've all seen headlines like this since the beginning of the COVID-19 pandemic, where ICUs around the country in the various hotspots have been overwhelmed by large and increasing numbers of critically ill patients exceeding standard capacity. And what this has led to is the implementation of surge strategies to maximize critical care capability and maximize our ability to care for those patients in need suffering from not only COVID-19, but the other afflictions that lead patients to come to our intensive care units on normal days. So in times of crisis where we have potentially or actually overwhelmed intensive care units, there's a concept called a crisis standard of care. And so the Institute of Medicine wrote a report about this back in 2009, and they defined the crisis standards of care as a substantial change in usual healthcare operations and the level of care it is possible to deliver, which is made necessary by a pervasive or catastrophic disaster. Now, the goal of crisis standards of care is to do the best possible job of meeting the existing standards of care in a crisis. There have been a lot of discussions about what crisis standards of care means and how we can implement them safely. The goal of crisis standards are not, or is not, to provide less care to patients. The goal is not to decide who is to live and who is to die. And the goal is also not to reduce our collective ethical burden to our patients, to each other, and to society. So again, back to the Institute of Medicine report, it was pointed out that in an important ethical sense, entering a crisis standards of care mode is not optional. It's a forced choice based on the emerging situation, and that failing to make these adaptations in how we approach large numbers of patients with limited resources at our hands is very likely to result in greater death, injury, and illness. So when we're thinking about crisis standards of care, you can look at both surge capability and then ultimately, when surge capability is exceeded, the concept of critical care triage. And we'll talk about both of those ideas. So there are three traditional pillars, if you will, of resource allocation: stuff, staff, and space. So stuff are going to be the physical things we need to take care of patients with. So ventilators, dialysis machines, the consumables, medications, and of course PPE nowadays. Staff, this is going to include acute care trained physicians, nurses, other clinicians such as nurse practitioners, PAs, respiratory therapists, pharmacists, EMTs, and then the other critical supporting staff who may not only be necessary to the running of the hospital, janitorial staff, food service staff, administrators, but also these are people who could also be at risk from the pandemic that we're dealing with, or whatever that public health emergency may be. Then lastly, space. This includes both our traditional physical ICU and ward beds. It includes notions of alternate sites of care, both within the hospital, like the PACU or the operating room, or potentially outside of the hospital, like a tent hospital, for example. And in the case of COVID, we also have to look at our availability of airborne infection isolation rooms, so negative pressure rooms. And I think we've all seen many hospitals, probably including most of ours, greatly expand our negative pressure capability. Overarching these three things are concepts of systems and communications, command, and control. Having a system, having a network through which different health systems can communicate with one another and have some means of organizing the allocation of the stuff, staff, and space during times of surge. This is a graphic by Dr. Mike Christian, currently in the UK, that just lays out that ultimately crisis standards of care are a problem of supply and demand. How on the side of increased demand, we have large numbers of patients, often with very long and prolonged and complex hospital stays, requiring large numbers of consumables, including drugs, to support their care. And then on the supply side, we have the stuff, staff, space, C3, and systems that we described. And how we balance those inputs on both sides really is what decides whether or not we are in normal operations, surge operations, or ultimately, as you see in the upper left-hand corner here, whether we have to impose some manner of triage, of deciding who in a group of patients who all would have a reasonable demand or reasonable need for some resource, who's going to get it and who we may have to withhold allocation of that resource for a time. So this is from an article done by the Task Force for Mass Critical Care with CHEST. This is first authored by John Hick back in Minnesota back in 2014, that just lays out this difference between these three broad groups. Conventional functions where we have, we're maximizing our usual patient care spaces. We may call in some additional staff. In general, under kind of a conventional surge, if you will, a typical ICU can usually expand its capacity by about 20% under ordinary circumstances. Once we start exceeding that, we move into what we call a contingency phase, where we have patient care areas that are repurposed. Maybe the SICU is now a MICU. Maybe we're using the PACU as overflow ICU bed. Maybe we're using monitored units like step down or telemetry for what would otherwise be ICU level care. Maybe we are substituting different supplies. So instead of rocuronium, we're using vecuronium. In general, in contingency, there's a minimal impact on usual patient care practices, and we are still operating within what we would recognize as a standard of care. In this model assumes that ICU expansion is about 200% or double your normal capability. So 100% increase over your baseline. Moving into crisis, then we are looking hard at non-traditional areas or for critical care, places that really aren't set up for providing critical care. The hallway, the ward. There may be insufficient ICU trained staff, and you're having to use a care team model where you are having hospitalists and maybe physicians who don't work in acute care working under the supervision of a small number of critical care trained folks. In general, the standards of care in this setting are not consistent with our usual standards of care, although again, we are still trying to meet a standard of care that is the best possible under the difficult circumstances. The resources available are going to vary depending on which level of surge we're talking about. In conventional, generally local resources should be adequate. Under contingency, or looking at resources from a region or a state, genuine crisis is going to require a national response. And we have seen variants of that during the current pandemic. So our challenge right now is that we are in a chronic contingency state throughout much of the United States, that there is not a single affected area that was struck by a hurricane or an earthquake that we can fly resources into easily, because there are so many potentially affected areas. And as we've seen in the last few months of the pandemic, where multiple states were affected simultaneously, that limited some of our ability to move patients around easily, although within California, for example, we've been able to do so with Imperial County moving patients out when they reached very much a crisis stage. So then, knowing that, let's go back and look again at those three pillars of resource allocation. So with stuff, we see that the scope of our current contingency can make our resource shortages chronic. We can still reallocate equipment between more and less affected areas. We can shift from single-use to reusable equipment, so we're seeing a lot more of, for example, reusable OR gowns for PPE, looking at reusable forms of PPE like PAPRs rather than single-use N95s, and also extending our use of N95s. So for staff, we have challenges of caregiver fatigue, burnout among frontline staff, and of course staff taking personal risks and potentially putting their families at similar risks. On the flip side, one of the effects on staff is that we are all getting better at this. So our increasing experience is having an impact on mortality, and we are helping people who we would have had a much more difficult time helping earlier in the pandemic. Lastly, space. We've expanded a lot of the space in many of our hospitals with increased numbers of negative pressure rooms. People have been able to do ward to ICU conversions and back. And in many hospitals, the wards are getting more comfortable with handling patients who are at a higher level of acuity. So, for example, patients requiring high-flow nasal cannula not necessarily going automatically to a step-down unit or to an intensive care unit. Now, whenever we talk about crisis standards of care, it's important to recognize that the decision to transition to such a standard is never the decision of an individual hospital. This is a regional decision to be made by some recognized public health authority, either county, state, or potentially national. So Our surge plans then within crisis standards of care need to be regionalized as well. So one hospital can't have one triage plan and then another hospital down the street has a different triage plan. These plans need to be integrated and worked out in advance. And on this slide, I have examples of a few successful models of that. The Minnesota Department of Health has generated one with a number of the health systems in that state. The Washington State Department of Health through the Northwest Healthcare Response Network has done something similar. Here in San Diego County, we've been fortunate to have great local leadership, both among our county Department of Public Health and the local health systems, who started meeting early in the pandemic to come up with an integrated response that allowed for sharing of patients, transfer of patients smoothly between different affected hospitals, and also allocation of a particular scarce resource, in this case remdesivir. So what are the kinds of things that we have to consider when we're thinking about allocation of stuff in crisis standards? So this is an infographic produced by Dr. Jeff Dichter and Dr. Rich Branson, looking at the kinds of ventilator models that are available in the United States through the Strategic National Stockpile. You see there's both full function ventilators and then ventilators for less severely ill patients, or maybe non-invasive ventilators that one could conceivably use for an intubated patient, or transport vents that have more limited capabilities. These are all available in some manner through the SNS and can be allocated to affected areas. The question becomes which vents are suitable for which patients. Some of these very simple transport vents, for example, are insufficient to help someone with bad ARDS who needs to be on 18 of PEEP or potentially bilevel, for example, but could be used for someone with a neurologic injury with intrinsically normal lungs who just needs pure respiratory support for airway protection. Deciding how to allocate those is going to be a challenge and really, again, needs to be done on a regional basis. This is another graphic. This is by Dr. Lisa Burry in Ottawa and, in Ontario. This is looking at some of the challenges with medication supply and drug shortages during pandemics. This is an article that a group of us prepared and is currently in press at CHEST. But essentially, we have problems in pandemics with both decreased supply because of a low incentive to produce some of these less profitable drugs that are the basis of much of what we do in critical care, like neuromuscular blockade or sedatives. These often have limited distributions, and these distribution networks can be disrupted either through the pandemic or through increased demand. The increased demand can lead to stockpiling of drugs, can lead to surges of patients, often the very lengthy hospital stay. And then we have these challenges we've seen in COVID where there's periodic spikes in drug utilization based on low quality data. So hydroxychloroquine, for example, as an agent that had sort of a run made on it early in the pandemic, which then subsided once further evidence came about the relative lack of efficacy of that drug in COVID. So what do we do when we're out of tricks, when our surge capability is overwhelmed and we have to start making some very difficult decisions? And some of those difficult decisions can be grouped together under the rubric of triage. The idea, and this is what we call tertiary triage within the hospital, is something we would need to do if we were to run out of ventilators. If you had 5 people with ARDS and you had 2 vents, how do we decide how to use that most precious resource in the way that maximizes outcomes? In general, the goal of crisis standards of care and surge is to avoid the need for triage to the greatest extent possible. Now, there is a large literature about triage, and I think we've all seen these articles in the New England Journal by Zeke Emanuel, by Charles Sprung, by many other medical ethicists and intensivists. Most of this writing has been about ventilators, and that was obviously a lot of the early concern and continues to be a going concern. But any scarce resource can be limiting and can require some manner of allocation system that we can group as triage. The exact nature of that allocation system is going to vary depending on what the resource is. So, for example, hemodialysis machines, CRRT, were very limiting in New York. Remdesivir is a scarce resource, and deciding how we allocate that is going to be different than how we allocate ventilators. So the decision to come into surge and to triage can be variable, and it's going to depend over time based on the number, the number of patients who are affected and what the local capability is. And this is just a graphic illustrating how a health system can move and or a region can move in and out of surge over time. Excuse me, this is actually the Sriracha almond sagistate, not my COVID, which is much better. Thank you. So in a triage system, we are seeking to identify patients most likely to benefit from critical care resources. What is the goal of triage? The goal of triage can be to save the most lives or to save the most life years. The principle of triage is to apply to all patients potentially being admitted to the ICU. So during the COVID-19 pandemic, if a triage system were to be implemented, you would apply to everyone requiring critical care, not just those with COVID-19. Even if a patient were to be allocated out, to say be withheld a mechanical ventilator due to a triage system, we retain an obligation to care for all patients, meaning that people who are not allocated a ventilator could still receive high-flow nasal cannula or non-invasive ventilation, or, if necessary, and it often might be, palliative care for those who would not receive it. And it's also important to remember that crisis standards of care are still standards. So there are a number of triage algorithms and a lot of research looking into what kind of method do we use to decide who would be allocated a scarce resource like a ventilator. Earlier versions of this talk, I went over different triage algorithms. Increasingly, I've found that there are, I think, some flaws in all of them, and I think the decision for any organization or any institution to develop a triage algorithm really needs to be made in collaboration with the local community. Dr. Lee Biddison at Johns Hopkins has done this in Harvard, for example, and really provided a model for how such a system could be implemented. But in general, triage algorithms are going to be a combination of measures of both underlying health status and the severity of the current acute illness to assess someone's odds of survival. So we look at both odds of long-term survival, and some algorithms have used your ASA score, frailty indices, comorbidity indices like the Charlson Comorbidity Index, and then measurements of the odds of short-term survival, so things like SOFA scores, Apache scores. There's a general trend to avoiding the concept of exclusion criteria, meaning there are no diagnoses that would automatically exclude one from receiving a ventilator, but there is a notion of lower prioritization for certain patients. For example, someone with a catastrophic intracranial hemorrhage or someone with coma following cardiac arrest with return of spontaneous circulation. Also worked into these algorithms are notions of tiebreakers for certain populations. So healthcare workers, pregnant women with viable pregnancies, children, and then the idea that pediatric triage and pediatric health systems should perhaps be considered separately from a system for adults, particularly in a setting like COVID-19 where the impact on children is not as great as it is in older adults. So the decision to go into triage, again, needs to be a regional decision made by some recognized public health authority, and the decision for triage should not be performed by the clinician at the bedside. That decision needs to be removed from the bedside clinician and then assigned to some sort of crisis care committee who will evaluate according to their algorithm what a person's score for, say, ventilator allocation would be. This is challenging. We did a lot of training in San Diego to institute such a system, a lot of tabletop exercises to make sure that individual hospitals' triage teams were ready and prepared to implement such a system if we needed to. And we're actually able to roll out a modified version of that when we received our first county allocation of remdesivir, for example. And I would just refer you to Dr. Devereaux's article from CHEST of 2008 that describes how a lot of this would work. Now, there are a number of ethical challenges in triage, right? The decision to withhold the therapy that we provide routinely to our patients is very difficult. One of the ways we try to lift some of that burden is through the implementation of a triage team, but that obviously doesn't remove all of that burden. Within the ethical challenges of triage, we have to consider things like the role of age. There have been a lot of discussion about the ethics of not providing a ventilator for someone based solely on their age. And I think there is a consensus that that is inappropriate. There's a notion, though, of life stages, that a person should have the right to move through different stages of life, through childhood to adolescence to early adulthood to middle age to being elderly, and that a person who hasn't gotten to move through all those life stages may take precedence in triage over someone who has lived what could arguably be called a full life. One of the challenges in addition to this is the idea of fair treatment of those with disabilities, that there actually have been lawsuits filed over triage plans against different states due to the perception that these algorithms would unfairly disadvantage people with, for example, chronic neuromuscular disease. And those are important considerations, need to be looked at. Equally important, especially in this day and age, are concerns about avoiding disproportionate impact on communities of color. That a lot of the comorbidities that are worked into these indices, especially looking at calculations of long-term survival, may have a disproportionate and unfair impact on communities that already suffer from a high burden of chronic medical comorbidities, such as chronic kidney disease, such as hypertension. And that those communities, being the same communities that have been hit hardest by COVID, are in a sense being told that they are going to be disadvantaged twice, both by the high risk of COVID and by getting downgraded, if you will, in a triage algorithm. And we need to find, as a critical care community, a way to avoid that sort of disproportionate impact, to make sure that we are providing care to those communities who have been hit the hardest by COVID. Then there's a question of what's the alternative, right? Do we use prognosis-based triage? Do we use first-come, first-served systems, which would in turn disadvantage folks who have less access to care, perhaps unreliable transportation, for example, or just purely random allocation? And some authors have advocated lottery as the only truly fair system, although again, the question of whether a prognosis-based system or random allocation which one would save the most lives and the most life years, I think remains to be determined. Now, what are the elements then of successful crisis standards of care response? So communication within health systems and between health systems, because it makes no sense for one hospital to be overwhelmed, but there to be available beds, available ventilators a mile down the road. Coordination, fostering teamwork between systems in advance of the crisis. And I have to say, I had the privilege of sitting on the San Diego County Committee, and seeing how disparate hospitals and disparate health systems came together so quickly was, quite frankly, a moment that made me be proud to live in San Diego. Lastly, an accurate inventory of resources. So we have to know how much stuff we have so that we can allocate it sensibly. So ICU beds, both routine and surge capacity, types of ventilators we have, the types of staff we have, the types of people who could augment ICU-trained staff. So hospitalists, emergency physicians, surgeons without formal critical care training who could back up and expand the capability to care for critically ill patients. We need to know how much stuff we have and how many people we have before we start planning our surge. I just want to acknowledge my many colleagues, friends, and mentors who got me to this point and gave me the chance to speak to all of you today. There are too many to name, but here is an introductory list. And thank you all for the opportunity to speak to you today. This is a fairly grim topic, but I think it's one that we've successfully implemented during this crisis, and hopefully learned a lot of lessons that we can use to continue to improve care going forward. Thank you all very much.